All right, well, welcome everyone this evening. It's so great to have you. And as we were just having a small little chat before the session started, we do want to acknowledge some of the insecurity that's happening here in Kenya. And we know that many of you are calling in from different countries where there's also could be some insecurity. So we at AHN just want to let you know that we are really proud of you as healthcare workers, wherever you're working. We really acknowledge the sacrifices that you make. Even in these types of protests, we still have to go to work as healthcare providers. So yeah, just wanted to take a moment and just acknowledge all the work that you're doing. We don't take it lightly. And I'm sure at the end of the call, Joseph seems like a very engaged person. If you're interested, I'm sure he'll love to talk with you about his thoughts on the situation. But thanks again for joining us. We're here at our Fireside chat, and once a month we get to host a kidney supportive care topic. And we're quite excited. We're in our fifth of our series. We come together once a month for this series. We launched, I think, in February this year. And tonight we have Dr.Peace Bashaga with us tonight. She's a clinical lecturer at Makerere University, College of Health Science and Palliative Care Education and Research Consortium in Uganda. She has a master's degree in internal medicine from the same university and a clinical fellowship in kidney disease from McMaster University in Canada. She's currently working on her PhD, which focuses on the quality of life of patients with end-stage kidney disease in Uganda. Kidney disease is the 13th leading cause of death in Uganda, and most patients are diagnosed late with very costly treatment options with increased poverty levels for their entire communities. And this is what her research is really being focused on. It's being conducted in collaboration with the University of Cambridge, and she is hoping to compare the quality of life of patients on conservative management with that of patients on hemodialysis. She's an excited educator, and she's participated in the curriculum development in Rwanda and works very closely with mentors and supervises multiple postgraduate and undergraduate students. She has a dream of one day setting up a specialized kidney disease training center in Uganda, as there currently is none. We're super excited that she's here with us, and she is a normal person, although this introduction makes her sound like a superhero. She is very easy to work with and very approachable. So if anything from her introduction has made you want to reach out to her, I know that she'd love to connect with you too. So over to you, Dr. Peace. We're really excited to have you here. The way we normally run our sessions is we have about 35 to 40 minutes of teaching, and then we offer time for question and answer. And I'll be on the call for the rest of today, kind of just answering questions in the chat. So over to you. Thanks for being here.
Thank you so much. Thank you so much, Erin, and thank you so much, the team. I'm so happy and privileged to be here today to share my thoughts. I hope to also hear your thoughts regarding renal supportive care. Thank you so much for attending today. So we're going to talk about pain symptom management, and it's going to be a case-based discussion. So our learning objectives today are really to understand the concept of quality of life, describe the holistic approach and the palliative care approach, and understand the concept of total pain, and also review some symptoms, not all of them, but some of them. So I'll begin by outlining our scenario for today. So EG was a 28-year-old male. He was a refugee from the Democratic Republic of Congo when I saw him. And he was, he presented to the ward with an EGFR of 3 for the very first time. He had gross anasaka, he had a BP of 189 and 121, and he was complaining of severe itching. He was not able to sleep. He was sitting up on his bed most of the time, and he said his feet were burning. He actually had a bucket of water, cold water, in which he would put his feet most of the time during the ward rounds. So to begin, this is the definitions by World Health Organization. I will give you 1 minute to read them. So the main thing in the definition for the World Health Organization is the fact that it looks at not just the patient, but their family as well. And it looks at preventing or relieving suffering. So its main focus is really on quality of life. And then The bottom definition is of kidney supportive care, taken from the kidney supportive care curriculum, which is actually published in the American Journal of Kidney Disease. And this is the first line of the curriculum, talking about what palliative care is and how it is applied. And when we are applying kidney supportive care, we really are trying to look at all the palliative care principles and apply them into the kidney care of our patients. So just to go back to the beginning, I thought I would begin by just telling you how I got involved in palliative care as well as nephrology. So in 2008, when I ended my medical school, I was really excited about, curing patients, getting patients better. And this is what a young, excited medical student has just become a doctor is really thinking about. But then in 2013, when I was doing my internal medicine rotation, I had a rotation with the palliative care team. This is a picture of me and a patient, one of the patients who I saw in my palliative care rotation. So this is a lady who had rheumatic heart disease. She had stage 4 cardiac failure. She had renal failure. She had, because of the infective endocarditis that she had got from the rheumatic heart disease, had to have one of her legs amputated. So she had only one leg. And she had severe cardiac cachexia. But she's sitting in her hospital bed, smiling and looking really happy with all of her morphine bottles. And this is really what palliative care is all about. So at the end of my internal medicine rotation, I asked my mentor, who actually took this picture, Dr. Maralene, if I could join the palliative care team, actually during my exam. And this was her mantra. She always said that for every patient you see, you should always tell the patient that there is nothing, there is no saying there's nothing we can do. There's always something that you can do. And this is how I got involved in looking after our patients with kidney failure and integrating them into the palliative care program. Because if you think about it, internal medicine, most of it is about managing problems, palliating problems for patients. Most of the internal medicine we do, we don't really cure patients. And we always have to think about what's coming next, what's coming next, what's coming next. So if you are a doctor looking after patients with internal medicine issues, you have to think about quality of life. And what is quality of life really? The Nairobi Hospice, this is their motto. They say it's about putting life into days and not just days into life. And you've had this quote from Dame Cicely Saunders about how a patient really matters at the end of, till the very end. So I just want you to think about what quality of life means to you and what quality of life means to your patients. And just jot down 2 or 3 ways in which you think the quality of life for you and for your patient might be different. I'll give you 1 minute to do that. Okay, so just looking at our patients who we see, there's trajectories to end of life. Professor Fleece-Matter did a lot of work in trajectories for patients and who have chronic diseases. So if you look at our patients who have end-stage kidney disease, most of them will come late in their disease progression, just like E.g. we talked about, our patients. The reason why is because we don't do a lot of monitoring, and patients therefore present when they get symptoms, and when they get symptoms is really at the end of life. And we know that only about 10% of patients who start dialysis will be alive at the end of 3 months. And Fleece-Matter's work showed us that patients who have end-stage kidney disease are almost similar to patients who have colon cancer. So they're almost similar to patients who have malignancies. And what is really terrible about them is that when they come, they have a huge symptom burden. So our goal really is to look at all the different symptoms and try to alleviate or manage the symptoms as we go along, and try to prolong life as much as we can in as much as a comfortable state for the patients as possible. So this work, again, from a UK group and a US group, looks at the symptom load for our patients. As you can see, the patients have a lot of symptoms, And this is comparing patients who are hemodialysis compared to patients who are getting conservative kidney management. For 6 out of all of these, out of these about 10, most of the time you'll find that patients who have hemodialysis would have more symptom loads, more symptom burden compared to patients who are on conservative kidney management. So patients who are on dialysis will have more pruritus, as well as more insomnia, more dry mouth, more muscle cramps, and more diarrhea compared to patients who are not on dialysis. The general principles for managing symptoms for our patients cut across for all the symptoms. So the first thing is you should evaluate, make a diagnosis of your patient's symptom, try to explain before starting the treatment of the patient, try to manage, try to individualize the treatment for the patient, continuous review because the symptoms keep changing and some of them will respond to treatment, some of them will not, and pay attention to detail. So talk to the patient and avoid making assumptions for the patients. So there's levels of complexity of care for the patient. You would have a low level degree of care, where everybody should be able to provide care for the patients, and trying to use the palliative care approach, because this is what we are hoping that we can be able to use in the kidney supportive care sphere. So provide the basic care as well as the intermediate care. And then if you do have a palliative care team, refer the complex symptoms to them. So in that case, we shall be able to provide care for all of our patients without saying there's nothing we can do. So the concept of total pain, again, relies on the idea of impeccable assessment of the patient, which is a core principle in the definition of palliative care. So total pain means that pain is not only physical, but there's a psychological, a social, and a spiritual element to the pain. So for example, my patient, he was a refugee. He's living away from home. He's living with his sister. He's in the hospital all by himself. He's separated from his son and his wife. He has a lot of distress. He's in pain. He's not able to sleep. He's asking himself, why is it me who has to have all these problems? So all the aspects of the holistic approach to care has to be thought about when you look after your patient. So what is pain? Pain is a really complex biopsychosocial disease and affects all aspects of life. And what I really like about this definition is that is the last part, where you really will not be able to successfully manage this pain if you use only analgesics. So that means that you're only focusing on the physical aspect. But in palliative care, pain is what the patient says it is. And what the patient says it is involves you talking to the patient, looking into the physical parts of their life, the social parts of their life, and as well as the psychological elements of their life, and trying to put all of that together as you come up with your management practice. So in looking at the physical assessment of pain, we classify pain according to how long the patient has had it. So either it's acute pain or chronic pain. Acute pain would be a little more easier to deal with, but the chronic pain becomes complex. And the nerve fibers that you're dealing with become enhanced in such a way that you have to use more than one analgesic medication. We think about the location of the pain. Is it the head? Is it the back? Is it all the joints? Patients who have psychological distress will actually tell you everything pains, because it's not just physical, but the psychological element of it. We look at the intensity, because that will tell you how much analgesia you're going to give, so mild, moderate, severe. And then we try to look at the etiology. Is it a nociceptive kind of pain? So is it like a muscle ache, or is it a neuropathic kind of pain? And if it's neuropathic, is it a peripheral or a central neuropathic kind of pain? So then we assess how much pain the patient has. And this also helps us going forward to be able to reassess, find out how is the patient changing based on the interventions that you're giving. So there's a numeric score where you grade 0 to 10, where 0 is no pain at all, 10 is the worst pain. And then there is the FACES score, which you would usually use for children. So a children is able to tell you which face represents how they are feeling. If they choose a smiley face, that means they're feeling happy. If they choose a crying face, it means that they're in really severe pain. So we use the WHO analgesic ladder and we modify it based on the renal function of the patient, eGFR of the patient. We will not use the NSAIDs and aspirin because that is contraindicated for our patients. And we will use paracetamol mainly for step 1. That will be our non-analgesics. And then we will use weak opioids. So that's tramadol and codeine for moderate pain. And we'll use strong opioids for severe pain. We do not have a lot of the strong opioids in Uganda. We only have morphine. So we tend to use morphine more. In other countries, they would say you should not use morphine because of the toxicity that it will have for patients who have renal failure. So morphine will be metabolized and most of it is actually excreted by the kidney. So when we do use morphine, we use smaller than normal doses of morphine. What we do is we increase the interval in between the doses. So instead of giving the regular 4-hourly morphine that is prescribed for non-renal patients, we would give a 12-hourly or 8-hourly morphine prescription, and we usually begin as low as 2.5 milligrams as we monitor for the side effects, which I'll talk about as we go along. So if a patient has nociceptive pain, so nociceptive pain is like, say, for example, you have patient has, say, for example, trauma to a muscle, or patient has had a headache. So that is what you'd call nociceptive pain. So you'd look for what are the non-pharmacological things that you can do for the patient. Exercise is good, especially for patients who have chronic fatigue, which they would describe as pain. Stretching, massage, acupuncture is really helpful. Behavior therapies, talking to the patient, relaxation techniques, group therapies, getting patients to talk to each other, because talking to each other also helps them to realize that they're not alone in their struggle. And then surgical interventions like ablative techniques and nerve blocks may also be applied in some centers. And then the pharmacological management will depend on how severe the pain is. So for step 1, we could begin with paracetamol, maximum of 3 grams daily. If the patient has, say, for example, joint pains, you may give them an NSAID, a topical NSAID. And then step 2, we'll move on to the opioids. So you can either use a weak opioids like tramadol or codeine, or you can use a very low dose strong opioids. That could also be a step 2 drug. So hydromorphone we don't have, but we do have fentanyl. Fentanyl is easily excreted. You can use it in renal patients. And morphine would use 2.5 milligrams 12 hourly because you're trying to avoid toxicity. What you would do is you begin with a trial dose for about a week, and then slowly increase the dose as you look out for side effects. So the common side effects would be things like drowsiness, things like if the patient says they're sleeping a lot, they're really weak, those would be the initial symptoms you look out for, as well as things like hallucinations. Every patient who is on morphine should also be on bisacodyl or lactulose unless they have diarrhea, because this will commonly happen to all the patients. And patients actually end up hating or refusing the morphine once they've had a severe bout of constipation. If they've ever had it before, they'll tell you, I cannot use that medicine because it gives me constipation. So to avoid that, make sure every time you prescribe morphine, unless the patient has diarrhea, always put a laxative or warn the patient about having a laxative on board. And then for neuropathic pain, this is because of nerve damage. The non-pharmacological measures would be like we have said, nociceptive pain. And then for the pharmacological aspects, first line will be gabapentin at a very low dose or pregabalin. If you use high doses, patients will be drowsy. I've used a high dose before and the patient ended up in an ICU, which was a really bad experience. So try to use really small doses and monitor them very closely for over short periods of time. So the next symptom is nausea and vomiting. Again, very common. Patients will have possibly because of constipation, delayed gastric emptying, if they have a huge ascites and they end up getting congestion in the abdomen and vomiting. Sometimes it's because of the drugs that we are using. So the first thing would be to try to use non-pharmacological management. So if they have constipation, you give them laxatives, encourage good oral hygiene because that can also affect their appetite. Remember, if they're very uremic, they have no taste because the tongue has lost taste. So encourage good oral hygiene. Give them small frequent meals, especially if they have huge ascites and they get early satiety. So encourage small frequent meals. Avoid alcohol. Avoid greasy foods because those will make them have increased nausea and make them vomit eventually. Medication optimization, and they should try to wear loose clothes because that also helps. So the pharmacological management will be first line. You can use ondansetron 4 to 8 milligrams every 8 hours. If you don't have that, then you can use metoclopramide. We have metoclopramide and ondansetron. Those are our common choices. Olanzapine is the other option, but not very common. What we will commonly use when everything fails is haloperidol. So use very tiny doses, 0.5 milligrams every 8 hours. Sometimes you may do it every 12 hours, and that usually helps actually. Haloperidol, metoclopramide, olanzapine are antagonists, so you should try not to use them together. Dopamine antagonists, so you try not to use them together. So this is an outline which was actually published in a paper. I have put the quote somewhere for it. In a paper we wrote about how to optimize drugs for patients who have end-stage kidney disease. So if most of our patients, as you well know, are on a multitude of medications, and these medications can increase nausea and vomiting. If a patient has kidney supportive care, especially towards the end of life, some of these medications are not really beneficial. So things like statins, for example, for dyslipidemia, you could consider discontinuing them because there's no additional benefits for a patient who's at the end of life. Antihypertensives, you can also relax on how strict you are with your BP targets. So we suggest about less than 160/90. If a patient has volume overload, consider using high-dose diuretics. And salt, we usually encourage salt restriction for most of our patients. So if you think that your patient is at the end of life, they're not eating because you've removed all the salts, then you should prioritize palatability of food rather than prioritizing salt restrictions. And then all of our drugs for hyperphosphatemia, we mainly give them because your patient may have low calcium or high phosphates. You could discuss whether you want to give the phosphate binders or not, and prioritize giving them nutrition, because sometimes you give very strict dietary restrictions because you're trying to avoid phosphate levels. So at the end of life, really, you would not think that phosphate high levels would be a priority. The priority would really be the patient's quality of life, allow them to eat as much as they can, because they will not even be eating that much anyway. And then anemia could cause fatigue and breathlessness. So if the patient is very fatigued and very breathless, you could continue using your iron supplementation as well as erythropoietin and blood transfusion if you have to relieve the symptoms. But if the patient has no symptoms, then you might consider stopping the iron, especially if the patient's at the end of life, and the erythropoietin. When it comes to breathlessness, sometimes you would think about if a patient is active or not. and fatigue as well. So if the patient is not very active, they're bedridden, they're not really getting breathless, then you would just ignore your iron supplementation as well as erythropoietin. And then when it comes to hyperkalemia, if the patient has acute high potassium, then you would consider treating it, but also based on the goals of the patient. I remember there's a time we had a patient who had hyperkalemia and was at the end of life, and we were discussing, should we or should we not treat it? And we eventually decided that maybe we should not treat it, because what is the goal of treating this hyperkalemia? It will make the patient have, needles to give insulin, to give calcium gluconate. The patient will have to buy the calcium gluconate. They don't have the money to buy the calcium gluconate. So eventually we decided that, this is end of life. Let's not treat the hyperkalemia. So you can discuss whether you're going to treat it or not for the acute episode. And then also for dietary restriction, the same applies. If your goals of care is that this is end of life, maybe you should allow them to eat as much as they want. Like I said, they won't be eating that much anyway. When it comes to metabolic acidosis, it would lead to fatigue, bone loss, muscle wasting. So you would consider whether you're going to continue with your bicarbonate treatment or not. And also, once you put your patient on the bicarbonates, you consider if you're going to be testing or not. So you may consider discontinuing the monitoring as you go along. The goal is really not to normalize the biochemistry of the patient, but to maximize their quality of life in the state that they are at. So what about breathlessness? What are the common causes of breathlessness for our patients? So one of the common causes would be if the patient is anxious, if they have anemia, if they have volume overload, if they have infections. So try to address each of these as you get them, if you can, and then try the non-pharmacological managements for your patients. So for example, for my patient, he was very breathless. He was very edematous. He had severe anasaka, and he was sitting up on his bed because he had a lot of pulmonary edema and pleural effusions. This is why he was sitting up on his bed all the time. He wasn't able to sleep because of that. So encourage him, tell him that sitting up actually helps as you try your pharmacological therapies as well. Also using the fast lip breathing sometimes helps. In patients who are severely breathless, blowing air on the face, usually using a fan or sitting by an open window, sometimes helps to control breathlessness. So pharmacological therapies, you could use supplemental oxygen, but sometimes using supplemental oxygen means that the patient is tied to their bed and tied to the hospital. So if there's no oxygen at home, it means that your patient is going to be in the hospital forever. So then the option of using combination diuretics then comes in case the breathlessness is because of volume overload. So you could use furosemide and metolazone. Sometimes the huge ascites gives them discomfort. So doing a paracentesis may actually sometimes help with breathlessness. If they're near the end of life, low-dose opioids have been found to be helpful. So again, doses like 2.5 milligrams 12 hourly of morphine might be helpful. Sometimes if you can, you'd use a fentanyl patch. That could also help with the breathlessness. Again, there's always a high risk for opioid toxicity, so you have to be very careful when you use it. So what about uremic pruritus? This is again very common for patients. There's a theory that it might be because of iron deficiency, may be related to iron deficiency. There's also theories that we don't really know which uremic toxin causes it, therefore which uremic toxin we should focus on. So there's a lot of work still going on regarding what is the exact cause of the uremic pruritus. But you have to go through the principles we talked about of evaluating your patient very well. One of the common augmenters is dry skin. Like you've seen in the dialysis population, they have a lot of dry skin. So making sure the skin is lubricated and moist may sometimes help for some patients. But sometimes you'd examine a patient and found that maybe they have scabies. So you have to factor that into your management protocol. So the non-pharmacological things would be things like giving moisturizers, keeping the skin cool and keeping the patient in a humid environment, avoiding scratching, because scratching makes it increases infection and make you end up with a cellulitis and keeping the patient awake, because also it will be painful. So the pharmacological management for uremic pruritus, you can use topical ointments. So we have capsaicin creams, which have been useful for patients, but they do cause some burning. So you have to warn the patient that they'll get some burning, but eventually they help. Hydrocortisone 1% cream may also be helpful. Gamma-linoic acid has an anesthetic in it, so it actually reduces the pain and might be helpful, but we don't have that in our setting right now. We have some menthol creams, which have been helpful for our population. And then if it's systemic, you can again give gabapentin, again beginning the very low dose, 50 to 50 usually milligrams, 2 hours before sleep. Other things like tricyclic antidepressants may be helpful. We don't have doxepin, but that has been recommended. But we have amitriptyline, and we usually will use a dose of 12.5 milligrams, which is half a tablet, and give it to the patient at night. It's not really clear if this actually helps the uremic pruritus or it helps because it makes the patient sleep at night. But that actually, that reduces, at least the patients say that they feel a bit better when they use amitriptyline, is what we've used, and gabapentin. So restless leg syndrome, I used to think it was a syndrome in the books only until I found it in 2 or 3 dialysis patients. So it's actually real. Patients will describe having their legs are moving all the time. They cannot sleep because they have to be moving all the time, and they are really uncomfortable. And it really causes a significant amount of insomnia for patients. They'll say they don't sleep at night, and when you probe them further, they'll tell you because they have to be moving all the time. So it's thought to be related to iron deficiency. Sometimes correcting that might help. Related to anemia and hyperphosphatemia, so correcting that might also help. Non-pharmacological things like reducing medications, like we've talked about, avoiding any stimulants like alcohol and caffeine, keeping the patient's the mind active, like doing puzzles, games. Sometimes exercise and good sleep hygiene have been found to be helpful. The pharmacological bit is we usually would begin with gabapentin, so 50 milligrams, again, 2 hours before sleep. And that has been, that is what I have used in my experience, has been found to work. Literature says that you can use second-line drugs, pramipexole, which I have not used before because we don't have that in our setting, but we have carbamazepine, which we have used. And the good thing with carbamazepine is you can use an even lower dose. Sometimes if you have really refractory restless leg syndrome, you can use benzodiazepines. So clonazepam is a good option. The problem though is that one, it's not very easy to get. Most patients won't be able to get it. And 2, there's a very high risk of falls and fractures because the patients remain drowsy. So if you can avoid it, then you would try to avoid it. But if you don't have a choice, then that would be the option that you take. Sometimes you can use the IV options, which is midazolam and diazepam, but again, the same things you have to be worried about is increased drowsiness. So you warn the patient, talk to them early, warn them, and then if the patient reports that they do get drowsy, then you halve the dose or reduce the dose to a quarter to see what will work for the patient. So finally, fatigue and sleep disturbance, again, is because of so many other possible contributing factors, so like hypothyroidism, electrolyte imbalances, medications, poor sleeping habits. So non-pharmacological measurements will be looking into each of these. Exercise is one of the things that really helps for patients. You know, most of our dialysis patients are in their beds most of the time. So trying to encourage them to get up, walk around, be active, socialize, very good, keep very good sleep hygiene, try to sleep at the same time every day, wake up at the same time every day, try not to sleep during the day. All of those really help the patients as non-pharmacological measures. And then the pharmacological measures, again, low-dose gabapentin, tricyclic antidepressants may be helpful, and we've used mirtazapine as well as melatonin. Those also have been found to be helpful for our patients. So to conclude, for our scenario, EG had really bad pruritus. They were unable to sleep, so they had insomnia, and they had peripheral neuropathy because of the significant volume overload that they had. They had really, they had anasaka really. So fluid in the lower limbs, the upper limbs, ascites, pulmonary edema, as well as a pleural effusion. So what we did is we gave him gabapentin, 50 milligrams at night, and that took away the insomnia, as well as reduced his itching. We also gave him capsaicin cream, which helped with the itching as well. And we managed to get a 500 milligram tablet of Lasix, which he took twice a day. And that was able to help to reduce. He lost about 1 kilogram per day of weight, of body weight. That actually helped. And then eventually we tapered it down and restricted his volume input. Unfortunately, he was not able to afford dialysis because the organization that he works for doesn't pay. The organization that supports refugees doesn't pay for dialysis, and he could not afford it. So he wasn't able to get dialysis. But we were able to get him a tiny radio, which was helpful for him at night especially. And we organized a visit with his son in collaboration with the social worker of the hospital, as well as the palliative care team. So that actually made him happy. So just going back to the point that there's always something that you can do for the patient. You never know what it is until you actually interact with the patient and pay attention to details. Thank you all so much for listening, and I look forward to your questions and comments.
Thank you, Dr. Peace. And we always do really appreciate these case-based learnings, because that's really how it comes back to our patients. And it's definitely a core value of supportive care. So thanks for bringing that situation. There's a few questions that came through the chat, so I'll just speak to them if you are able to help us. So Teddy asked a question. So there's evidence for increased cardiovascular events in patients with chronic kidney disease. What is the rationale for considering discontinuing their medications such as statins? Yet, I don't understand the second part of the question, but especially related to some of the other, I think the other medications, maybe iron supplementation, phosphate binding. Yeah. So how, I guess, maybe how do you make those decisions of what to discontinue, what to not?
So the main thing really is having a frank discussion with the patients, establishing what the goals of care are for your patients, and then establishing which medications will be beneficial long-term and short-term. So in terms of statins, there's long-term benefits to taking statins, but no evidence for short-term benefits to taking statins. So as you saw our trajectory, patients who start dialysis, 10% are going to be no longer on dialysis by 3 months. So that means that most of those patients are going to fall off and die. We know that patients who are completely anuric will not last more than 14 days. The amount of anuria, the amount of urine output determines how long your patient will be with you for. So if you're sitting down with your patient and discussing with them, you then look at all the individual drugs that they're taking and see which is a long-term beneficial drug and a short-term beneficial drug. And you choose to keep the short-term beneficial drugs. For example, the drugs that are going to make them less breathless, make them less pruritic, make them less, give them less muscle cramps. Those are the drugs that you probably opt to keep, but long-term drugs you probably will not keep because the patient may not be alive long-term.
Mm-hmm. And sometimes these are really difficult decisions to make, right? We,
Yes.
again, if it's not an area that you're completely comfortable with, or you don't have colleagues that really support you in making these decisions,
Yeah.
again, it's not always black and white. So
Yeah.
making sure that you do seek out people
Yeah.
that can kind of help you make these decisions. Again, it's
Yes.
not the way we normally practice medicine and nursing, yet it is
Yes.
really important in the population that we're serving. A good question from Joseph. So I'm just curious about the use of gabapentin in restless leg syndrome and uremic pruritus. Is there a specific advantage of gabapentin over pregabalin in these cases? So thoughts more on the neuropathic.
There's really no benefit of gabapentin over pregabalin. They're the same class of drugs, and if you have pregabalin, you use that. If you have gabapentin, you use that. The most important thing, though, is to begin small. So with gabapentin, we'll begin with 50 milligrams, increase to 100 milligrams, and then slowly, progress like that. With pregabalin, would usually begin with 25 milligrams, increase to 50, and then to 75. I don't use pregabalin a lot because our pregabalin is a capsule which you can't break, and it's 75 milligrams. So I don't use it a lot for that particular reason. But if you have a 25 milligram pregabalin, that's as good as a 50 milligram gabapentin. The point is start small and monitor your patients as they go along.
And is there a difference in costs? I know that we obviously have people calling in from many different places where, sometimes you can't access all the medications. Do you know in Uganda, is there a difference in cost for these ones?
Yes, so there's a difference in cost. In the public hospital where I work, they usually will have gabapentin, but sometimes they don't have gabapentin or pregabalin, and they have carbamazepine. So we use carbamazepine if we have no option. So depending on where you have and what you have available to you.
A question from Emmanuel, and then I'm going to switch over to the Q&A section. So Emmanuel is asking, is there a role for steroids in breathlessness, or when our patients are having shortness of breath? Breathlessness.
So I've not really come across a role for steroids in patients who are breathless, unless you think maybe the patient has, unless you think there's some inflammation or some sorts, but usually I've not come across a role for steroids in a patient who's breathless. So unless you think there's inflammation that can be sorted by that, I don't see one.
A question from Sharma says, how do you manage anaskara in end-stage renal disease, which is not responding to diuretics?
So you try to, I think she means
typo.
Anasaka maybe
Okay.
She means volume overload.
Yeah.
So,
sorry.
So you'd use maximum doses of Lasix. Lasix is a high ceiling diuretic. So you try to use maximum doses of Lasix. You try to combine loop diuretics and thiazide diuretics. Try to reduce, encourage patients to stop volume overload. In our setting, usually when patients have renal failure, they'll tell them to drink a lot of fluids. So they end up getting overloaded because of that. So sometimes talking to the patient, finding out why they overloaded in the first place may be helpful. So, so educating the patients, maximizing your Lasix dose, trying to tap the places where you may have fluid congestion. For example, if you have a huge ascites, if you can tap that, that will help. If you have a huge pleural effusion, if you can tap that, that will help. If all of that completely fails, then you'll have a frank discussion with the patient, explaining to them what's happening, and then manage the breathlessness, because that's usually the biggest problem. So the breathlessness, manage the skin ulcers, because they'll get skin ulcers. So manage all the different complications as they come along. If you're able to dialyze them, then you would start dialysis. Sometimes there's the option of palliative dialysis in some settings, which we don't have for our patients.
There's lots of comments here. Another one from Steve and Sylvester, all related to, I think, what you just mentioned, high doses of Lasix, and isn't it going to cause more serious complications? So I don't know if you want to make one final comment about that. So do we monitor serum sodium to avoid hyponatremia, which could be a serious complication? isn't it also an adverse effect like ototoxicity? So lots of concerns related to how do we manage this symptom? Obviously, we want to be symptom focused, but then, yeah, concerns seems to be from the group.
So,
Sorry,
like
Dr.
said,
Peace.
so like you say, Lasix is a high ceiling diuretic. And actually, every time I prescribe high dose Lasix, all the new pharmacy interns will send back the prescription, and I have to educate them again. So it's a high ceiling diuretic. Other practices or other disciplines will usually use tinier doses of Lasix. In the renal world, we'll use much higher doses of Lasix. So you start small and keep increasing until you get to a dose that works for you. So for us, we usually would begin with about 100 milligrams 2 times a day, and then see if the patient is making urine or not. So you have to monitor their urine output, because that tells you if you need to increase your Lasix dose or not increase your Lasix dose. And then you will usually we'll do a daily weight, because the urine is difficult to collect sometimes. So we'll do a daily weight and keep titrating the dose upwards. We've been able to get this 500 milligram tablet, which actually works sometimes for us, and helps to make them make a bit more urine, because sometimes it's really resistant. Of course, there's the worry about ototoxicity, and that is real. So you have to make sure you examine your patient every day, tell them about the side effect, and ask them to watch out for the side effects as often as they can. Thank you.
The questions keep coming, so I'm just going to put them back to you, Dr. Peace. You've been great tonight, and people seem to be quite interested. We have over 100 people on the call, which is great. Okay, so is there a safe use of oral NSAIDs for pain management for our dialysis patients? So oral.
Not really. Not really. We try to encourage topical NSAIDs. We try to avoid the oral NSAIDs, because you're trying to protect the residual renal function as much as you can. So if you can avoid anything which is going to be nephrotoxic, because that residual renal function is the difference between how long your patients live, especially if your patient has end stage and you're not going to dialyze them. So if you're trying to delay dialysis as possible, try to avoid any nephrotoxic medications if you can. So
questions going back to the pregabalin and gabapentin. I'm not sure if this was in your slide. I didn't see this, but why do we take it 2 hours before sleep? Had you mentioned specifically when to take it?
Yes, it's 2 hours before sleep, because it will make your patient drowsy. It will make your patient sleepy. So you take it before sleep.
Perfect. A question related to nose bleeding. So what causes nose bleeding for chronic kidney disease patients after dialysis?
So if it's specifically and only after dialysis, it may be because of the heparin that you're giving them for dialysis. So they may get heparin-induced bleeding. And what you would then do if it's specifically for dialysis, then you would try to reduce how much heparin you use during dialysis, or try to do heparin-free dialysis for your patient.
Some interesting questions. Dopamine agonist versus gabapentinoids for restless leg syndrome. Which one is better?
So you would begin with gabapentinoids, because those have been proven. Most of the studies have showed that those are the better option. Again, like I said, restless leg syndrome is not really clear about what the etiologies are, and the non-pharmacological measures seem to be better than the pharmacological measures, but the gabapentinoids seem to be a better option of care compared to any other drug that has been tried before.
Okay, kind of question we didn't seem to focus on too much today during your presentation, yet I think it's quite important. So I'm glad we have a few more minutes to focus on this. So just related to some of the psychosocial support, and especially when we're treating children, I don't think we talked about that too much today, yet how I know that you work with a variety of patients. So how does your team support pediatric patients that may be requiring dialysis? And do you use social workers or do you use other types of therapy? This question is related to a child life support.
So
how
the
do we
palliative care
support?
team,
Yeah.
so for this, I would again look at, remember that the tiers, we looked at the levels of palliative care that you provide. So there's the universal level, and then there's the, moderate level, and then the really complex level pain or level symptoms for the patients. So when you have evaluated your patients, like I said, you go through the same process every day, really try to evaluate, look at what is the cause of the symptoms, if there's any psychosocial issues involved. Once you have evaluated the patient, then you'd see what level of care they would need. Mm-hmm. If it is a complex level of care and you need multidisciplinary input, usually we will ask the palliative care team to come in. The palliative care team would have access to social workers, mm-hmm. would have the time to sit down with the patient, their family, and try to explore and find out where the problem is, and try to see how they can provide the multidisciplinary care that the patient needs. So there is levels to care, and you have to be able to have people you can call up who will come and help you with the different aspects of care. For example, the social worker will help us in this patient's case. The social worker helped us to get the patient's family to come in and visit him because he was hospital bound. He's been in hospital for a long time. The social worker is also able to coordinate with the chaplain to come in and talk to the patient for spiritual care. All those different aspects of care will come in when you're able to work in a multidisciplinary team. And these are cases that you will discuss together and try to find out what is the solution, because it's difficult to think of a solution by yourself sometimes on a busy ward round. So having a support system is good, and discussing these complex patients makes it helpful.
Looks like there's one more question about pain. So what are some safe analgesics in advanced non-dialysis kidney patients, chronic kidney disease patients, and then also for people that are elderly?
So safe analgesics, the commonest we use is paracetamol. Paracetamol is safe. You can use as high as 3 grams per day. So that's usually 1 gram 3 times a day for an adult. The other analgesic we commonly use is oral morphine, because we have a production unit in the hospice. They produce morphine, so morphine is easily accessible for most patients. And morphine can get, you can get metabolites of morphine with renal failure. So you have to use a tiny dose of morphine. So we try to begin with the tiniest dose available and then work our way up. The tiny doses of morphine also help for breathlessness. So if a patient is very volume overloaded and very breathless, you may give them morphine for the breathlessness. It also works for the pain, and then try to find out what else, what are the other issues involved in the pain. So if there's anxiety, if there is insomnia, if there is, psychosocial elements to the pain, all those will be helpful as part of your cocktail of managing the patient.
A question came through on the chat. Not sure I fully understand the question. Dr. Yuri, do you see this? What can you say about the myth that water treats kidneys?
So
is that a myth I'm just not aware of? Could be.
No, I think so. The idea is that we tell our patients with kidney. So when we talk about prevention of kidney disease, we say drink plenty of water, keep yourself hydrated, and make sure that you don't get dehydrated, because the kidneys work with water. And if you're well hydrated, you prevent all the problems that come. That's likely to cause kidney disease mostly. So the myth is that we tell all of our patients when we're trying to prevent kidney disease to drink water. And so when patients develop kidney disease and they have end-stage kidney disease, they will be listening to the same message. So what we are doing is telling patients that there is a category where you drink water and water helps And there is a category where you don't drink water because water makes you sick, becomes a toxin. So that is probably the myth that we're talking about, that they might be talking about. If you have end-stage kidney disease, water is toxic, don't take water. If you're trying to prevent kidney disease, take plenty of water because you have to be well hydrated.
Yeah, it can be confusing, especially at in different communities or where people have limited access to education. It can be a bit complicated.
Yeah.
Okay, so I think you addressed that. Dr. Yuri has added in a few links in chats. I actually just wanted to make a really quick announcement from us as AHN. We had an amazing day today. We hired our first 2 palliative care nurses here in Kenya for AHN, and we're building our team. So I just wanted to announce that to over 100 people online. We're really excited. Dr. Yuri and I, are going to be working really closely with 2 Kenyan nurses, and we're onboarding them, and we're just really excited. So Dr. Peace, I'll definitely introduce them to you. As we kind of grow our team, you're going to be continue to be a really big resource for us. And I think just based on the chat and the engagement, it seems like everyone has really been encouraged by your teaching tonight. So thank you. Thanks, Dr. Peace. Dr. Yuri, I'll pass it over to you for a final thoughts.
Thank you, Erin, and thank you, Dr. Peace, for a very enlightening talk. I think, actually, I know that some of the cases that you have discussed actually happen on a day-to-day. Actually, on my side, I was consulted on a patient today, has massive ascites, pulmonary edema. We had advised that we even put in a pigtail catheter for paracentesis, just for continuous drainage. But again, you get a patient who's already anuric. You cannot optimize diuretics, and we want to de-escalate care. So the option is, again, with the family conference, you just have to dialyze. Because now with the fluid overload, it can't get out. You can't use diuretics because they are anuric. So yes, I think from time to time, we just need to curate individualized care plans, patient by patient, of course, together with consultation with the family and also the patients. As much as we want to do conservative, sometimes you find it might be difficult, again, once you have the discussions. But again, this was an eye-opener. Thank you for the great discussions on different modalities, both pharmacological, non-pharmacological, that we can always leverage on for our patients. And we look forward to actually having more sessions with you so that, again, we can learn on what you're doing and in that space. And even as we are growing our team, as Erin has mentioned, I'm sure we'll work very closely together to work on patients, not just in Kenya, but East Africa and the whole of Africa. And on behalf of Africa Healthcare Network and our panelists, I want to convey my thanks for making time to join this meeting today. I'm sure Dr. Lloyd will want to say one thing or two, so I'll hand it over to Dr. Lloyd. Thank you.
Thanks, Yuri. Thanks, Dr. Peace, for this wonderful session on pain and symptom management. I think great insights and great expertise, especially as Yuri mentioned, on the day-to-day affairs that we actually face, day-to-day clinical challenges that we face, invaluable knowledge and support. And I think it'd be wonderful for you to also be in a part of our program as your next door neighbor to us. And I'm sure Yuri and Erin can reach out. I will actually copy a mail to them as well, so that we can actually work together, especially on the program we are rolling out. You could give us advice and also the research possibilities of local importance. As you are a local guru, we would actually definitely like your inputs. So extremely grateful. And we definitely hope, to interact with you in many ways, as well as more sessions out here. Thank you so much. Thanks, thanks, Erin. Thank you.
Humbled by the invitation. Thank you so much.
Thank you. Thank you very much.
Thank you.
All right. Good night, everyone. Have a safe time wherever you are. Be careful, and we'll see you back for most of you next week, and then for the rest of us once a month. Bye now.
Yeah.
Bye.
Thank you, Erin.
Thank you.
Thank you. Thank you.
And just as a matter of announcement, this session will be uploaded on our YouTube channel. So kindly, once it's uploaded at Africa Healthcare Network YouTube channel, you can check it out. I know some of you have been asking about slides in the chat box, so probably you can follow the discussion there as a reference point. And I'm sure you learn more on a few areas that you probably didn't catch in the presentation. Thank you. Thank you, Dr. Peace.
Thank you, Yuri. Thank you so much for the invitation.
Thank you so much. It's a wonderful session.